to come. Okay, so I will turn it over to Teresa. Thank you.
Good afternoon, everybody. I'm excited to be here, and I'm going to move now into a more sort of practical front, sharing about a case study from Memphis where we actually were able to turn the needle on disparity, a cardiac case study. Oops, sorry, excuse me. Oh, sorry. I'm going to start with looking through the lens of the Congregational Health Network, which is a faith community and community partnership, health system and faith community partnership, specifically a cardiac case study in which we were able to actually decrease sudden cardiac death in African Americans in the course of about 18 months. And I'm also going to use the lens of highlighting practices of signaling between community and collaborating health systems to kind of show these practices that are designed to mitigate the asymmetrical power dynamics that you often see in these partnerships. Health systems are usually have more money, more power, more resources. They often are the biggest employer in the community, like Memphis. And I want to also say that communities are very keenly aware of these dynamics, and they're looking to the majority power group to say, hey, can we flatten these curves? Can we have a more horizontal table? Can we even flip the power dynamics somewhat? And we're also going to talk a little bit about the evidentiary link between community power and health equity and why it's difficult, and some of you have already discussed that. But for a minute, let me just share with you the landscape of Memphis. Many of you know the disparities, health disparities in Memphis, because we're talking about cardiac case studies. The cardiovascular disease rates in terms of mortality for African Americans is twice that of white folks. We also have terrible diabetes, cancer, suicide and homicide, infant mortality, and even the health income, economic health income for whites is about twice that of the average African-American family. At least in 2010, that was still the case. So there's just some really egregious things going on in terms of disparity in the city. We're going to look through the lens of the Memphis model of the Congregational Health Network. This was a partnership between now over 700, mostly African-American, 86% African-American congregations and Methodist Lamont Health System. It was started in 2006 under the leadership of Gary Gunderson and Reverend Dr. Bobby Baker, who's pictured here, to improve access and health status for all in the community. And as I said, because of those disparities, that was a big job. CHN has had some good outcomes through the years, and it's a very robust, powerful, it demonstrates faith community power in the city in terms of people cared for in this network had decreased charges over the years, decreased half of the mortality rate, longer days to readmission, more people navigated to hospice and home health in a very distrustful community. And then our place-based efforts in one of the poorest zip codes in the country, 38109, also showed that we were able to turn the needle on our charity care there. But let's fast forward to 2009. This was an Aligning Forces for Quality grant, AF4Q. Many of you are familiar with that Robert Wood Johnson initiative, where we were looking to standardize our racial, ethnic, and our race, ethnicity, and language preferences in terms of just collecting the data to start with. Like many health systems, we hadn't done that. We rolled it out to all our systems by 2013, and we found we had to have a biracial and multiracial option for people to look at. Another arm of the study was looking at ideal measures of cardiac care across that racial, ethnic, and language lens. And Methodist North, where this program was based, was run by Paula Jacobs, who was the Director of Quality Improvement at Methodist North. Did really well. They were top of the heap in terms of the 8 sites. We were only one of the southern sites that surpassed ideal care goals for congestive heart failure at 96%, heart attack for 100%, once people made it to the hospital for those cardiac measures. So we were able to deliver that care regardless of race, ethnicity, or language. But the bad news is that where African Americans were dying at twice the rate of whites of sudden cardiac death on the way to the ED or once they reached there, and they were not coming back within that 30-day period. So we were trying to figure out what was accounting for that disparity. It was not an issue of a difference in it was pretty much equal in terms of whites and African Americans coming to Methodist North. But 64% of the African Americans were dying at a young age of 58, and only 36% of the whites were dying at about an age of about 67. So there was a difference there. And so this brings us to our first lesson learned and signal too, is that to achieve community health equity, the work needs to be community-led and initiated. And we've heard this theme over and over the last few days. But there was a huge disconnect between the health system values and metrics and leaders and those of the community. Paula Jacobs was delighted because her team had been top of the heap in ideal care. So she thought it was an opportunity. But our CHN members and leaders and faith community leaders like Bobby Baker there, Perry Little, who runs the CHN Academy or our training unit, and Shirley Perry, our navigator, were just horrified because it meant that people in their community were dying. So they had a very different view. Other things that we've learned: be teachable health system, have a long-standing humble relationship. And that was demonstrated in this case by then CEO Gary Shorb, allowing this data to be shared transparently to the media. And in fact, the local collaborating community partnership didn't really want us to do that. But he said, we've got to have community input to change this needle on this health disparity. So in addition to meeting with Paula, we had a series of other meetings in the room where we kind of looked at that dialogue about race and elephants in the room. And they were very tense meetings. And then our CHN Liaison Council, which was a self-organizing group of women, allowed us to come to the broader group, share the data, and get their input on why African Americans were dying at higher rates on the way into the ED or once they got there. So what was some of that community intelligence? Well, we know minority distrust of hospitals was shared, and anyone who's ever read Harriet Washington's Medical Apartheid knows the reason why. People did not have coverage, so they didn't want to run up bills. They had medical fatalism, hopelessness regarding their future health status. And then we had a very lively and interactive educational back and forth with community members about best practice medications that differ from most of the white majority populations studying research trials. Started usually with white males, then white females, and only in the last few decades have we gone to subgroups looking at racial and ethnic differences. In this case, calcium channel blockers work better in terms of preventing future heart attacks in African Americans and whites than beta blockers. We shared that. People in the community shared with me about the issue of impacting men's manhood in terms of taking medications and issues around compliance. It was a very stimulating conversation. And then we shared with the group something we learned in this process, that prodromal and presenting symptoms, the major one for heart attack in African American and Hispanic women versus whites, was that debilitating fatigue. And there was a gasp in the room when we shared that, because what underserved woman who works a couple of jobs, cares for family, maybe even grandkids, is not tired all the time? And so we shared with the group, we really need you to be aware that any female family or friends that have that symptom need to get to the doctor soon, very, very soon. In the partnership work, what we did then, Paula and her team shared best practice medications, information about minority patients with our medical staff, and that was very uncomfortable conversations at times. We developed with the community input culturally sensitive, low literacy teach-back tools about preventing CHF and heart attacks, and we decreased the amount of discharge materials, which was then 48 pieces of paper, to just a few pieces of paper. We co-branded our CHN Academy, this was our training program, to teach in our chronic disease and community health worker courses to use those same materials so people in the community would get used to it. And we stressed the need to go to the hospital if you had certain acute symptoms. We did make a difference. We made a difference in terms of decreasing the disparity for African Americans by 15% in the period that we went back and looked again. And then we did some more work. We continued. We changed our systems bioethics committee to be the ethics and equity committee. Remember, the language is really important here. And then Sunny Anand, who is also an intensivist at the Children's Hospital, began looking at Hispanic data and found that our Hispanic children were dying at almost a 4-fold rate compared to African American white children in the NICU and the PICU. And so he started a 3-year intervention, multi-level community and hospital intervention that also decreased disparity. It's published in JAMA Peds, which is a beautiful article. So let me say just a couple quick things about measurement assumptions. Social complexity really means that life exists within the interconnected web of systems and relationships that shape the social and physical context in which we live. But like community power, it's messy. It's messy to measure. And I think there are some things that you've already heard from Bill and others in the last couple of days, but our traditional tools and metrics are not adequate. We've got to be creative. We've got to use mixed methods. We've got to also have iterative learning cycles and informative evaluation, like plan, do, study, cycles, et cetera, that you can take those metrics and you can quickly make program changes, make quick policy changes. And it needs to be non-extractive. The work belongs to the community. It's the community's data. They get to interpret it, and they need to constantly interpret it, share it back with us. And then lastly, I'd say that building trust and integrity of the work and program are more important than the rigor of the design or the metrics that you use, because building trust is what this is all about. And a healthy community is a powerful community. So I'll stop there. Thank you.
Thank you so much, Teresa. I'm really seeing some through lines in terms of mixed methods, making sure we really build community trust and ownership, and being creative just in terms of using that mixed method approach.